Good morning, ladies and gentlemen. My name is Piotr Kabata, and I will having this seminar with you. We'll talk about general principle of poisoning management in in many cases that the poisoning is involved. Uh, the main idea that we have to remember is that every acute poisoning must be treated as potentially life-threatening, even when the patient seems to be asymptomatic during the initial evaluation. However, we have to remember that we shouldn't be scared of the patient. We have to evaluate the patient. We have to diagnose the patient. We have to provide him with basic means of diagnosis, the same way we would do to any other patient with any other condition. We don't care whether it's myocardial infarction or a stroke or a poisoning. We have to follow the basic rules of what to do, when to do, and then do what we have to do. However, remember, every poisoning might be potentially harmful, potentially dangerous, as in some of the cases the symptoms will develop only after 5-6 hours even. Usually it will be around 2 to 3 hours from ingestion or from intoxication to the development of the syndromes. Of course, the time span may differ. Well, basically, when we have to deal with a patient, to diagnose the patient, we have to first we have to assess patient's condition. As with any patient, we have to consider his consciousness level. We have to check whether he's in respiratory failure or in circulatory failure. So your basic ABCs: airways, airways, breathing, circulation. So basically, we have an unconscious patient. You do the same way you would do in any other patient. Well, if the patient is conscious, then it's much easier that way. When we have secured that basic phenomena, we should start with differential diagnosis, assess severity of the intoxication, check for any possible complications, or we have to treat the complications. Also, we have to take care about concomitant conditions, as well. As usually most of the patients won't have only one one disease, one illness. However, bear in mind that most of the patients who are intoxicated will be relatively young. Therefore, well, usually they won't have many concomitant conditions. Many of our patients they're just young, healthy people of 20 or 20 something. So basically in their 20s or even in their teens or late teens, complications or somatic burden. When we start our differential, we have to check whether we're talking about poisoning, maybe other pathology. Many patients will present just as a sudden unconsciousness. Well, when the patient is unconscious, we have to look for a bunch of other stuff like hypoglycemia, some other metabolic conditions, head trauma, or anything like that. So look for that. Remember that poisoning is usually a very rare condition. So first try to rule out all the other conditions, unless you have pretty clear case that someone has seen the patient taking the medication or anything like that. So then it's pretty straightforward from then. Once we have the potential of poisoning, we see that the patient might have been poisoned. Let's look for what was the poison. Frequently there will be a mixture of poisons. Well, when we're lucky, we will see a case of a patient like I had a patient like that. I had such patient yesterday that he was found unconscious. However, around him there were lots of boxes of of medications being found, some bottles of alcohol. So basically, we had an idea of what we might be dealing with, of what are the consistence of that mixture of poisons. However, in case of mixed poisoning, we have to remember that we may see different symptoms of different xenobiotics, so different toxin happening in various time. So, well, you may see a patient who will not present with some of the symptoms because one of the other poisons have have basically limited the other symptoms. Sorry. Okay. Then we try to assess the severity of the patient's condition. We look for the symptoms. If we have a possibility, we try to check the poison blood levels, or sometimes it's just enough for us to check whether the poison is in the systems. Look for, well, for example, benzodiazepines, which are basically, well, qualitative measurement is good enough for us because we know that the patient is intoxicated with benzos. We don't need to we don't need to look for the precise concentration, as it doesn't correlate to patient's condition. So we have seen patients who had their benzos quantified with very high levels, presenting almost no symptoms, while we had patients who had relatively small concentration of benzodiazepines in very severe condition. We look for the complications very frequently, and we have to bear in mind that many patients will develop pneumonia, frequently aspirational pneumonia, as any additional bonus of possible vomiting. So the patient might try to, let's say, clear his own gastric tract by vomiting. However, when you're unconscious and you try to vomit, well, it may end up in, well, the vomit may end up as well inside of you as outside of you. So you might also vomit, well, not only outside of the patient, however, also inside of the patient. So he will vomit into his own gastric tract, or her. So first, we have to classify the consciousness level. In clinical toxicology, we usually use a so-called Edinburgh scale or Matthews scale. It's a very easy scale. It consists of 4 grades. Well, to be honest, 5 grades, because we start with the level 0, which means that the patient doesn't have any symptoms, doesn't have any quantitative consciousness disabilities, so he's fully alert. If we have grade 1, the patient is usually sleepy. He might be comatose, however, he will be logical, he will be reacting to verbal stimuli, of course, the pain stimuli as well. However, well, he will have a tendency to fall asleep. When we have the grade 2, patient will react to pain, will react to other stimuli, however, they have to be pretty strong, and usually the interaction will be very limited, if at all. Then we have number 3, grade 3, which means that the patient will react only to strong stimuli. Of course, in that case, don't expect any logical interaction. Most cases he will just try to move your hand away, or just move a little. However, will not have any contact with the patient. And number 4 is the condition in which we have no reaction from the patient. Of course, save for some basic reflexes like calf reflex or ciliary reflex. Usually it will correspond to GCS, so Glasgow Coma Scale 3 to 6 in most cases. However, it's not that easy to translate from GCS to Matthew scale. You have to remember that GCS is a pretty easy and straightforward scale. However, it has been developed to deal with patients following the head trauma, and uh, in case of intoxicated patients, we can see a very rapid onset of changes of coma, frequently with patients ranging from GCS 5 to 10 or 12 in matter of minutes, then back to 6, again 9. So that might be very, very flexible. Therefore, be careful when dealing with, well, when using GCS scale to to assess the patient in case of poisoning. Uh, of course, remember that when you have a comatose patient, try to determine their blood glucose concentration as soon as it is possible, as you might see uh, severe hypoglycemia presenting as bunch of other diseases. We have seen patients who were suspected of alcohol poisoning. We have while they had very, very low levels. I have seen patients who were suspected of a very massive stroke, only to assess their blood glucose concentrations to be around 19 or 20 something milligram percent, and therefore we have treated that, well, stroke, that apparent stroke, only with glucose, with complete recovery of the patient and lack of other symptoms. Then we have once we have managed the consciousness level, we have checked the consciousness level, we move to airways. Of course, as usually, we try to remove the obstructions. If the patient has problems with providing his own airways, we try to put the Gedel tube or Mayo tube or a nasal tube just to provide him with clear airways. Sometimes we may need to perform endotracheal intubation. However, remember, we are not using GCS as guidance to as guidance for the decision to perform endotracheal intubation. GCS 8 is, of course, an indication to intubation, however, only in patients with head trauma. In other cases, you have to look for other causes, especially since many causes uh, severe coma in case of poisonings might be potentially reversible. Look for naloxone in case of opioid poisonings, or flumazenil in case of benzodiazepines. Also, naloxone will be useful in case of clonidine poisonings and many, many others. Sometimes administration of the antidote might either delay the need for intubation or even make it unnecessary, make it just useless, because patient will start to breathe on his or her own again. When we have to assess the ventilation, what do we look for? Of course, we look for the breath rate. Remember, when someone breathes slower than 6 breaths per minute, or faster than 30 or 40 breaths per minute, then we have to then we can see that something is going on. Remember that breathing rate above 40 is one of the 40 breaths per minute is one of the indications for potential intubation of a patient. Well, in fact, just yesterday, I had to intubate the patient with his breathing rate of in his 50s around. So that was enough for us just to perform the intubation, connect the patient to the ventilator as he was getting more and more sick. And after the intubation, everything corrected itself with the use of mechanical ventilation, of course. Look for the respiratory effort. Sometimes the patients will have well, technically, their breath rate will be more or less okay. Um, However, you will see that they're using their accessory muscles. They're using, well, whole of their chest just to take in, to breathe in the air. So that might lead to, well, basically making the patient tired of breathing. So they may just, well, run out of their energy and stop breathing altogether. Look for dyspnea, look for bronchospasm, which might, especially in case of poisonings with some gases, it might lead to the patient, well, basically dying, as asphyxiating himself. Um, Look for pulse oximetry of a patient. However, some poisonings might give you false readings. In case of hypothermia, you will not, well, you might have very low levels, even in case, well, even with, well, normal or semi-normal blood oxygenation, as the vessels will be collapsed. The pulse oximetry meter will have pulse oximeter, sorry, will have problems with getting a good reading. Also, in case of carbon monoxide poisonings, we will have, well, something that goes another way around. So we might have falsely elevated SpO2, as the blood will be much, much brighter. Therefore, uh, therefore it might look uh, like the patient has much higher level oxygen level in his blood. However, right now we have more and more pulse oximeters that will operate on several spectra of, or length waves of the spectrum of the light. Therefore, they might assess carbon monoxide concentration, or even sometimes uh, we may be able to assess metchemoglobin in those patients, even using the simple pulse oximetry. However, they are not very widespread yet. Uh, the go-to test for us in case of problems with ventilation will be ABGs, so arterial blood gases measurement. Um, when the patient fails to ventilate properly, we have to think about causes of that ventilatory failure. There might be either of neurological causes like depression of CNS, central nervous system, respiratory center, or they may be a result of respiratory muscle failures. So basically, the problem mm, with the peripheral ventilatory system, let's say. The cases of respiratory muscle failure will be usually some toxins that cause problems with nervomuscular plates. So that might be botulinum toxin, that might be uh, some junction blockers, might be some scoline, might be some rocuronium or other anesthetics. Uh, it might be some organophosphates which destroy the acetylcholine esterase, which is needed for proper recovery of acetylcholine. It might be strychnine, it might be tetanus, it might be also some of the snake venoms, as snakes, well, snakes used to use their venom to paralyze the victim. Many poisonings or many toxins will cause depression of central nervous systems. Many of them will act through the GABA receptors, so the well, the inhibitory system of our organisms. That will be ethanol, other alcohols for that matter. Um, it might be some sedatives, benzodiazepines, barbiturates. Also, well, opiates and clonidine will act through opioid receptor. We will have tricyclics, which will also cause CNS depression. So a large group of poisonings, especially those that are working sedatively, in big enough, in a dose that will be big enough, will cause CNS, respiratory center depression, and therefore ventilation failure, ventilatory failure. Another thing we have to care about is hypoxia, because sometimes the patient ventilates correctly. He will breathe in, he will breathe out. However, the gas, the oxygen won't reach the blood, or will not reach the target cells. It might be due to impaired gaseous exchange, like in case of pneumonia, some aspirations of some hydrocarbons or other volatile substances, some irritants, or other causes, so-called pneumonitis, which is just basically inflammation of alveoli. In some cases, we will have pulmonary edema, so basically the lungs are filled with fluid, which impairs the transport of oxygen from lungs to the blood. Usually it will, usually it's hard to tell whether it's usually, but it might be either non-cardiogenic or cardiogenic. In case of cardiogenic, it will be, in most cases, those will be the medications that act on heart, or so basically the beta blockers to some extent, calcium channel blockers, or other medications that will act directly on the contraction of, or contractive abilities of the heart. We can have non-cardiogenic edema, usually from fumes, from irritants. Similarly as with pneumonia, irritants can cause both pulmonary edema or pneumonia. It also depends on the level of solubility of a given gas. So some may cause edema, some will cause pneumonia. Some hydrocarbons also can cause edema, sometimes even a very, very long time from the exposure. Same way with chlorine. There are cases of pulmonary edema showing up after several days from the exposure to the poisoning. Therefore, some of the experts say that following chlorine exposure, you should observe patient even up to a week, as they may develop the symptoms very, very lately. Sometimes the airways are okay. The gaseous exchange in the lungs is good. However, we will have hypoxia in the tissues, either by action of cyanide, by hydrogen sulfide, carbon monoxide, with different mechanisms. Some of the toxins will just take place of oxygen in hemoglobin. Some will impair the mitochondrial chain, or other properties of the cell. Then we have ARDS, so acute respiratory distress syndrome. There are several diagnostic criteria. You have to remember that ARDS is a very, very severe condition that may frequently lead to death of a patient. Well, what are the symptoms? Well, the first one is sudden onset. It's not a condition that will develop over many years or days. Well, basically it's in the name. It's acute respiratory distress syndrome, not prolonged or chronic or whatever. You have the very easy diagnostic criterion, which is a relation of PaO2, so arterial oxygen pressure, but remember it's from ABGs, from artery to inhaled oxygen fraction, so a VO2. Basically you can assess it when you have the patient under mechanical ventilation. It's the easiest way. However, in case of air oxygen, if the patient is still is not ventilated, you can assume that it will be something around 36 to 40% of air. And if that relation is below 200 millimeters of then you can, then you can diagnose a patient with IRDS. You can have bilateral densities on chest X-ray. You will have pulmonary artery wedge pressure, which is the parameter that isn't used that often anymore. But if it is below 18 millimeters, um, then, well, the patient is being diagnosed with ARDS. Mm, well, usually the X-rays will show diffuse changes in both lungs. Sometimes they might be limited only to some fractions of the lungs, but usually they will be symmetrical in both lungs. Okay. Hypoxia might lead to many complications. Some of them are very important, and we try to well, be safe from them, because they might lead to very severe degradations of patients' life quality, mainly permanent central nervous damage, which is the condition that, well, um, deprives the patient of many of his life qualities. Hypoxia might lead to arrhythmias. It might lead to, a myocardial infarction or any other examples of cellular death. How do you manage the hypoxia, the patient with problems with getting the oxygen to target cells, target organs? Well, first thing, we try to do what we can to stop the exposure. We use oxygen therapy. Sometimes we will use 100% oxygen, be it carbon monoxide, hydrogen sulfide, cyanides, or other compounds that may lead to deprived hemoglobin function. We may use a hyperbaric oxygen treatment. However, first thing, we have to have access to such hyperbaric chamber. Well, if the patient has severe hypoxia, usually he will or she will need intubation, ventilatory support using mechanical ventilations with sometimes a very high PEP, so peak expiratory end pressure. So basically, we try to fill the lungs with air, just to prevent the alveoli to collapsing the alveoli. Sometimes we will have specific antidotes. In case of cyanides, for example, sometimes if a patient develops pneumonia, we will use antibiotics. Sometimes we need to employ steroids if a patient isn't intoxicated with something that will cause a stridor. We may use salbutamol, or we may use some theophylline, depending on the substance. Well, what are the causes of bronchospasm? Usually it's either direct damage or allergic reaction to some substance, or, well, direct effect of a toxin. Well, allergic causes are pretty straightforward. Well, the patient is allergic to something, be it a medication, be it a bee sting, or any other thing. Well, you know how it works. Some substances might cause a direct damage to bronchi, usually irritants or fumes, or aspiration of hydrocarbons, or aspiration of gastric content. Some of the substances, like beta blockers, organophosphates, carbamates, or many other substances, may act on bronchi, just cause them to spasm, to constrict. It's a pretty, well, you should know that you cannot give beta blockers to patients who are asthmatic, as it may cause bronchospasm. Well, management of bronchospasm is also pretty easy. It's usually similar to other causes. So you stop the exposure, you give oxygen. If it was caused by beta blockers, well, you withdraw the beta blockers, or if well, the cause of bronchospasm might have been other, but the patient is being treated with beta blockers. You just withdraw them, you just switch to some other medication, just to prevent yourself from having to, well, checking if they were the causing factor. You might use bronchodilators, which I said a moment before, so beta-2 agonists, some anticholinergics, some theophylline, or in fact any other metalloxanthine. If you're somewhere in, well, out there in the fields or in a camping trip and you have someone developing bronchospasm and you don't have any theophylline on you, you may give the patient very, very strong tea or very, very strong coffee that will alleviate the symptoms to some degree. Sorry. If you have an access, feel free to use steroids. Feel free to use atropine in case of organophosphate poisonings. It's very, very useful. Also, in case of organophosphates, we use something called oximes, so substances that reactivate acetylcholine esterase, which is the target enzyme for the organophosphates. When we perform the physical examination of a patient, first we look for the respiratory rate. What can be causes of hypoventilation? So to slow breath rates, we use the mnemonic slow, so sedatives or hypnotics, liquor, so basically ethanol or other alcohols, opiates, and weed, so marijuana or other analogs. When the patient is hyperventilating, he's panting, well, think about the pant as a mnemonic as well. So that might be PCP or other stimulants. That might be paraquat. That might be pneumonitis. It might be ASA, so acetylcysteine acid. It might be non-cardiogenic pulmonary edema. It might be toxin-induced metabolic acidosis. After assessing the breathing rate, the ventilation of the patient, we can start assessing the circulation of the patient. Well, the first thing for which we look will be bradycardia or atrioventricular block. It might be caused by various cholinergic drugs, vagotonic drugs, amphibostigmine, organophosphates, you name it, many protecting agents and so on. Might be caused by digoxin. Might be caused by some cell membrane stabilizing drugs, basically many antiarrhythmics, tricyclics, and many drugs like that. Well, they may also have effects on other systems, as the effect of cell stabilization is a very multispectral. Some adrenergic system blockers will cause bradycardia, might cause AV block. Basically, adrenergic system is the one that causes our heart to beat faster. So once we block it, well, it will be, the stimulation won't be there anymore. So the patient will be in bradycardia. As you know, beta blockers will block beta system. Clonidine will block alpha adrenergic receptors. Many other agents will cause bradycardia. Might be hypothermia, might be lithium salts, which act as a replacement for natrium in our organism, sodium, basically leading to problems with bradycardia. Might be calcium channel blockers, mainly diltiazem or verapamil. Okay, how do we manage the bradycardia? Usually we use either isoprenaline or, as a first line attempt, atropine. Usually it's either 0.01 to 0.03 milligram per kilogram IV. So for normal patients it will be usually 1 to 3 milligrams per patient. Sometimes we need to use pacing, either external pacing or percutaneous pacing, depending on what we have. But ventricular tachycardia or ventricular fibrillation might be caused by many agents. Some of them will cause increased sensitivity of cardiac tissue, of myocardium to catecholamines. The very common group of substances in here will be hydrocarbons. So some patients following and sniffing some pain or sniffing some hydrocarbon dissolvent and led to some adrenergic stress, whatever, might develop VT or VF, ventricular fibrillation or ventricular tachycardia. Many sympathicomimetics may cause tachycardia or ventricular fibrillation in high doses like cocaine, amphetamines, theophylline, or other meloxantins in large enough doses. Other substances also may lead to VT or VF in various mechanisms, either digoxin, TCAs, also some other substances. In case of many substances, we can see QT prolongation and, well, leading to torsade de pointes. Frequently, well, what we have to be aware is that even if the patient has prolonged QT, it will be much more dangerous for the patient if he has also, well, if he has a very slow rhythm. So basically, QTc prolongation with fast rhythm will be usually much better tolerated and much safer for the patient than the one with slow rhythm. Here we have to think about sotalol, amiodarone, hinidine, some TCAs, phenothiazines, hypercalcemia, hypomagnesemia, many other causes. Unfortunately, torsade de pointes may lead to ventricular fibrillation, may lead also to other severe ventricular arrhythmias and also to death. Now, bear in mind that in clinical toxicology, we use a little bit different standard of QT prolongation, and usually we treat a QT prolongation as important if QTc is above 500. So a little bit longer than in cardiological cases. Okay, we have sinus tachycardia and supraventricular arrhythmias. Sinus tachycardia might be caused by sympathicomimetics of stimulants, amphetamines, cocaine, theophylline, ephedrine, or whatever, methadone or other catenones. Some anticholinergics might cause tachycardia or arrhythmias. Atropines, phenothiazines, well, TCAs, some mushrooms or antihistaminic plants or hallucinogenics. Also, tissue hypoxia will cause sinus tachycardia as our heart wants to make up for the lack of oxygen, so it can only pump the blood faster just to give more, to hope to get more oxygen. So think of carbon monoxide, hydrogen sulfide, or any other substances like that. How do we manage that? We sedate the patient. If it's adrenergic, we might give some beta blocker, usually propranolol or esmolol. We can give physostigmine in case of anticholinergic. However, it's considered very unsafe in case of tricyclic or tetracyclic antiarrhythmics, as it may cause very. The main causes of bradycardia can be described by mnemonic again, paced. So, well, basically, when you have bradycardic rhythm, and then you pace it. So remember, paced. It might be propranolol, like a symbol for all the beta blockers, or poppies, so opiates. A will be for acetylcholinesterase drugs, C clonidine calcium channel blockers, ethanol, other alcohols, and D for digoxin. So the most common causes of bradycardia. Tachycardia is a state in which your heart beats fast. So fast consists of freebase, so freebase cocaine, anticholinergics, antihistamines, amphetamines, as will be for sympathicomimetics. Note that, amphetamines are also sympathicomimetics, I hate this name, and solvents, and T for theophylline, and to be true, all methyloxanthines. As you know, well, you know the effect of caffeine. If you, well, study for too long and drink too much coffee, you will be tachycardic, you will be feeling not that well. Well, we've dealt with different rhythms. Now time to deal with blood pressure. Well, as with any state, we can have either hypotension or hypertension. Uh, well, the most common causes of hypotension are, well, vascular relaxation, hypovolemia, decreased cardiac output, hypothermia, like in any cause. Um, well, the causes of toxic causes of hypotension can be described by a mnemonic crash. So C will be for clonidine or calcium channel blockers, CCBs. You might find it somewhere. R for reserpine and other antihypertensives. A for antidepressants, aminophylline. S for sedative hypnotics. So all the benzos, opioids, and so on. H for heroin and other opiates. As you can see in those mnemonics, sometimes the names overlap. Next one will be hypertension. It is very, very common. However, sometimes it's not exactly an effect of a toxic substance itself, but it might be cause of, well, a result of agitation, of delirium, or of pain. For example, in patients who are burned chemically some way, or after some trauma. But the most common cause of hypertension, like toxic hypertension, are sympathicomimetics, be it amphetamines, methamphetamines, cocaine, catinols, ephedrine, monoamino oxidase inhibitors, who act by, well, inhibiting the distraction, the dissolving of monoamines like adrenaline, dopamine, and so on, leading in turn to increased pressure. Well, the causes of hypertension will be named by mnemonic CT scan, cocaine, thyroid supplements, sympathicomimetics, caffeine, anticholinergics for amphetamines, and nicotine. You may find it in many places. In fact, most of those mnemonics are taken from Emergency Medicine Journal from 1996, usually. Hypothermia, well, is a result of one of two causes, either exposure to low temperatures or impaired thermal regulation. For some reason, be it, well, barbiturates, be it ethanol, which leads to widening of small vessels and increased body heat dissipation. Drugs that lower glucose levels, which also cause hypothermia. In turn, we have hypertension, which can be caused either by increased heat generation or decreased dissipation of heat. In case of dissipation of heat, all the drugs that will cause contraction of vessels, either anticholinergics, phenothiazines, antihistamines, and other drugs like that. Drugs that cause, agents that cause increased heat generation might either increase metabolism, like salicylates, thyroid hormones, or things like that, or cause increased heat generation, either by seizures, by increasing muscular tone, or causing the rigidity. It might happen, in fact, after every neuroleptic, well, as they might cause something called NMS, neuroleptic malignant syndrome, but also stimulants like amphetamines, like cocaine, like lithium, or TCAs may cause increased heat generation. Causes of hypothermia are the most common ones, are either carbon monoxide, opiates, or opioids to be true, Oral hypoglycemics and insulin, well, all the hypoglycemics, liquor or ethanol, and sedatives, as in many cases you can see. Causes of hyperthermia, uh, NMS or nicotine, antihistamines, salicylate, sympathicomimetics, anticholinergics, or antidepressants. Um, the next, well, in fact, this will be a complication of many intoxications, are seizures. Seizures can be caused by many factors. Very frequent cause of seizures is withdrawal syndrome from different substances. It can be sympathicomimetics like amphetamines, from ethanol or from opioids or so on. Seizures can be caused also by sympathetic mimetics like amphetamines, cocaine, especially in high dose. Also, all of the drugs that act as cell membrane stabilizers or natrium channel blockers may cause sorry um, may cause seizures, like antidepressants, mainly TCAs, neuroleptics, or other multiple drugs, also hydrocarbons. And what is important to note, most of anti-epileptic drugs or anti-seizure drugs may also cause seizures in terms of poisoning. Some substances will cause dystonias. Dystonias are, well, they're muscle contractions that will cause a very specific twisting and abnormal posture. It's usually unilateral with patient looking at one side, frequently upside, well, to one of the sides and up. Frequently, those contractions will be sustained, will be lasting for prolonged time. Also, uh, they will be very painful. Well, the cause of that is depletion of dopamine. Therefore, many dopaminergic drugs might cause them. A pretty frequent cause is metoclopramine. Uh, Usually very well, they're very easily managed with the use of biperidine, or known by trade name akineton, uh, which will quickly well replace normal muscle tone. If you don't have access to biperidine, then you can use some benzodiazepine. Some anticholinergic drugs will cause involuntary muscle movements. They will look very similar to tics, sometimes similar to chorea. Uh, they might cause reduced voluntary movements. What is important, they can be worsened by biperidine, by akineton. However, benzodiazepines will be very effective in most of cases of those. Okay, after poisoning, one of the things we try to do, or we may do, we used to do it much more frequently, is gastric decontamination. It could be done by several methods. The easiest one, however, it is frequently contraindicated and it may cause many grave consequences, is inducing emesis. It used to be a go-to method in United States, where they were giving patient ipecac syrup. Right now it has been withdrawn due to numerous complications of this procedure. Well, you cannot do it in patients who have deprived consciousness, who are unconscious, the patients who are in seizures. Also, after, well, ingesting any corrosives, hydrocarbons, or any foaming products like shampoos or so on. As you may imagine, when you add a lot of water to soap, well, it will cause produce production of foam, which may be inspired, and which may go to the lungs and cause aspirational pneumonia. Uh, Usually, if you do the contamination, you use it with water, sometimes with normal saline. However, well, um, it might be not as effective. And well, if you try to do it, do well, perform it only up to an hour from ingestion. As I mentioned, ipecac, who used to be popular in US, right now has been removed from the market. Uh, the go-to method and the gold standard for many years of gastric decontamination was gastric lavage. Uh, Usually, you just put a large bore catheter into the patient's stomach, usually through the mouth. However, if you have well, in some cases you may try putting it through the nose. However, usually then you will use a smaller catheter. Then you give water or saline in case of small children. Um, Repeatedly, you give it and evacuate it. Usually around 100 to 300 milliliters, some say 200 to 300 milliliters at a time, or a smaller dose in case of children. Usually we try to take it around 10, 15, sometimes 15 milliliters per kilo in children. Uh, it is very useful when the ingested dose is very significant, is very large. Also, it has to be done in the first 1 hour, well, in some cases 2 hours from the ingestion. Uh, well, there used to be a trend among pediatricians to perform gastric lavage as a way of teaching kids that, or children to be true, that you cannot eat any medications and so on. Unfortunately, it doesn't work, and it might lead to a lot of severe complications. Um, a common misconception among patients and but also among physicians is that whenever you have a intoxicated patient, you will perform gastric lavage. As I mentioned, that used to be true. However, for many years now, we perform scarcely any gastric lavages. I think that it will be less than 5% of patients needing hospitalization, most probably even less. Also, due to the fact that many patients will not arrive to the hospital in that time frame that, well, it is useful to perform that procedure. In some cases, you may prolong the time from ingestion to gastric lavage to up to 2 hours when you have SR drugs, so slow release drugs, or pharmacobezoars, mushrooms. However, you have to remember, because it's also a misconception that has been brought up in many countries, that gastric lavage will be effective only in case of substances, toxins that are ingested, that are done, well, just eaten or drunk or something like that. It won't be effective in case of, I don't know, gaseous inhalation or envenomation by some spider or something like that. That's not how it works. You have to have a substance in the gastric tract to be able to get it out of that. You have also always to well, balance the risks and potential gain from the procedure, as in any procedure to be true. Uh, if you have any doubt whether you should perform gastric lavage or not, well, you may also always contact your local poison center just to be sure if it's useful. Uh, what are the contraindications of gastric lavage? Well, for sure, when you are poisoned with corrosive substances, as there is a lack of, well, there is a risk of performation. However, there are some claims that you can use a small lumen catheter if you are up to half an hour or even less time from ingestion of a corrosive substance, and then you may try to suction out some of that. However, it's usually limited to the cases in which you see the patient ingesting given substance. as I mentioned before, if you have volatile substances or hydrocarbons and so on, well, the gastric lavage will not be effective, so it's contraindicated. Also, in case of detergents or other things that might cause foaming, well, there is a risk of aspiration of the foam, so rather try not to do that. If you have a patient who is unconscious, who has unprotected airways, well, try to protect the airways, intubate the patient, and then you may think about performing gastric lavage. However, in most cases, if the patient is already unconscious, then usually he will be beyond the time frame of gastric lavage. Marked agitation, dangerous. You may cause some perforation of gastric tract, so it's very dangerous. And one of the most important contraindications is lack of consent, especially since well, for the past few years we already know that it isn't as effective of treatment as we used to think. So if the patient doesn't agree for that, doesn't give us consent for gastric lavage, then usually we should skip that. Well, but we always have to inform him that, well, in such case the poisoning might be much more severe. AC, so activated charcoal, is another way of protecting our well, of preventing absorption of xenobiotics, of toxic substances. Right now we think that we can give it almost anyone. Well, basically clinical toxicologists just love charcoal, so we like to give it in most substances. It might be beneficial. There have been several large studies discussing administration of activated charcoal, which say that it's in most cases it's very useful, or at least useful to some extent. Of course, indications might be similar to indications for gastric lavage. However, due to specifics of pharmacokinetics, it may be also beneficial even up to several hours following the intoxication. So, for example, in any substance that has a biliary circulation, it will be useful also after many hours from intoxication, because the substance will be will be put back to the gastric tract, so we can take it out from there. In most cases, you will use approximately 1 gram per kilo of a patient. Well, so it means that usually it will be from, well, for an adult, from 30 to 100 grams. Some people say that you may use a little bit lower dose in adults or in older patients, so sometimes you can give half a gram per kilo. A useful way of giving activated charcoal is giving it at the end of gastric lavage. So then you just put it as a last portion of a fluid, then you don't evacuate it back again. You don't perform the gastric lavage with the charcoal slurry, because you may end up with having aspirational pneumonia with very severe complications of that. Now let's go to antidotes, which are another important important medication, important treatment modality in many poisonings. Basically, we can divide antidotes into two groups: non-specific antidotes and specific antidotes. The non-specific ones will be activated charcoal, will be chicken egg white, which might be used in case of some protecting patients in some corrosive ingestion, sometimes in case of metals. However, it's Well, it's always difficult. Well, for once, it's difficult to obtain when you're working in the hospital. It's not that well, you may ask someone to go to buy some eggs, but it's not that easy. Uh, However, it might neutralize some substances, especially chicken egg white is done is well given to a patient by dissolving it, well, 3 to 4 egg whites into half a liter of water and then giving it to a patient to drink. Also, you may use milk as a dissolving agent. Mm, it might be useful in some cases. It will bind some of the corrosives, some of the other substances. Sorry for the noise. My dog is here. Uh, Another non-specific antidote, at least it's considered a non-specific antidote by some authors, is oxygen, which will be an antidote given in, well, to be true, mm, in every gas exposure. Uh, it's useful to have some regimen of oxygen administration. One of possible ways of giving it is giving the 100% oxygen for 3 hours, then giving 50% oxygen by for 6 hours, and then giving well, normal oxygen or some low flow oxygen for several more hours, usually around 16. Then we have specific antidotes. You have a basic antidote kit, which will be, well, to be true, it is different in different countries. Some countries will have will have their central antidote bank to which you can, well, ask. In some places you just have to have your own antidote kit. Then you're limited to some extent to what your pharmacy has. One of the countries in which they have an, well, countrywide antidote bank is Sweden, where they had the central antidote bank in Stockholm, and I think they also have some peripheral smaller banks in some other cities. So just from going through the basic antidote kit, we have atropine, which is used for organophosphates, for carbamate pesticides. We have piperidine, as I mentioned, for dyskinesis. We have calcium, which can be used to treat intoxications with oxalates, with fluorides. Uh, Pretty rare condition. However, it might be seen in some workplace settings. Cholestyramine, which used to be given in digoxin poisonings, to be true, it's not that frequently given anymore. We have dantrolene, which can be used in severe hypothermia. We have ethanol, which is basically the antidote for most toxic alcohols. Well, namely, it will be usually ethylene glycol or methanol. However, you can also use it in isopropyl alcohol. However, usually those intoxications are relatively benign, so frequently you will not have to use that. Well, it can be given as 96% alcohol or 40%. In some places, you can give intravenous doses if you have, and then usually you use 10% ethanol. In other countries, you just have to give the oral ethanol. Then usually you go for something around 40 or 20% of ethanol. Flumazenil is one of the drugs you should know. It's an antidote for benzodiazepines. We have glucagon, which is useful in most cardiac medications, so beta blockers, calcium channel blockers. Also, it's used in glucose lowering drugs as a substance that will cause the release of glucose. In case of poisoning with acetaminophen or APAP or paracetamol, those are just different names of the same substance, you give NAC and acetylcysteine either in oral doses over 72 hours or using Prescott's protocol over 21 hours intravenously. Sometimes you can use other shorter protocols like SNAP, which last for 12 hours. We have naloxone for opiates, but also can be used in intoxications with clonidine. We have physostigmine, which I have mentioned before, to use in case of anticholinergics. We have very useful vitamin K1 or vitamin K, which we use in case of poisonings with coumarins, with varfarins, with super varfarins, so many rat poisons, and agents that cause, reduce the blood clotting. We have vitamin B6, which is also known as pyridoxine. We use it in treatment of intoxications with isoniazide and some other cases as well. For the most common lethal toxins, well, we will have some differences between adults and children. Well, some basic substances will be similar because everyone will be susceptible to cardiovascular toxins, to cleaning products, or large doses of antidepressants or iron, toxic alcohols, and gases. However, in adults, it will be very frequent to see fatalities following antidepressants, some drugs of abuse, usually cardiovascular toxins, analgesics, sometimes theophylline, or a recent trend, caffeine, as now you can get large doses of caffeine, and we have seen we have seen severe intoxications with either suicidal or recreational with caffeine. There are some drugs which will be fatal to toddlers and young children even after very small dose, even sometimes after one tablet or one singular dose. It might be camphor, chloroquine, tricyclics, phenothiazines, quinine, salicylates, theophylline, iron supplements, especially the ones that will have a lot of iron, also cardiac medications. Basically, I'm summing up. Well, we try to use intensive but minimally invasive treatment in case of our poisoned patients. We try to do whatever is needed, but we do it when it is needed. We try not to, over-treat the patients. And we treat the patient. We look at what is happening to a patient. We don't treat the poison or the concentration because, the end result is survival and good condition of a patient. Primum non nocere is the main principle, as you know, so the first thing is not to do harm. And the essential thing, especially in the early hours of intoxication, is monitoring of patients, both cardiovascular parameters, consciousness level, also the ventilatory parameters, if you have any examples. I would like to thank you for listening to that maybe a little bit lengthy presentation, and have a nice day.